Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're doing another Kahoot, and we're going to be talking about prioritization and delegation. These two concepts are so important because you are going to be incorporating them throughout your entire academic career to become a nurse. And then when you become a nurse, those are one of the two most important things that you're going to be doing. So you have to understand these two concepts. Now, before we get started, as always, I'm going to ask you to please support me and support this channel. How can you do this? Like this video. Go ahead and give it a thumbs up now. You're going to love the video. Subscribe to my channel if you haven't done so already. And be sure to check out my website, nexusnursinginstitute.com. There you can sign up for next generation NCLEX review session. There are two parts. Part one, where I teach you how to think like a test writer. I teach you about prioritization, delegation, critical thinking. And then in part two, we actually go over NCLEX type questions, scenarios, rationales, the most important things that you need to know. You can also sign up for a private one-on-one tutoring session, or maybe just want to pick my brain about something. If you're currently in the nursing program, I have audio lessons available. If you are struggling and you have to do really well on your next couple of exams, be sure to check out the audio lessons I have available. And guys, with no further ado, let's get started. Priority and delegation. Okay, you're caring for multiple patients. Which one should you assess first? Is it a patient with a history of hypertension complaining of a mild headache? Is it a patient 2 hours post-op with a pulse oximetry reading of 88%? Is it a patient with a urinary tract infection complaining of dysuria? Or is it a patient who's scheduled for discharge later in the day? Very good. The patient 2 hours post-op with a pulse ox reading of 88%. Whenever you're being asked which patient you're going to assess first, what the test writer is really asking you is who is at the most risk of, right? So first red flag, 2 hours post-op. Any patient who just had surgery, automatically, the fact that they just had an invasive procedure, we're going to be concerned about hemorrhage. We're going to be concerned about them developing a DVT or pulmonary embolism. We're going to be concerned about them developing an infection because they had an invasive procedure. The risk of introducing pathogens into that patient's body is absolutely high. So these are three huge concerns that we're going to be worried about just because they just had surgery. So that's our first red flag. They just had surgery. Second red flag, look at that pulse ox, 88%. Normal pulse ox is 95 to 100. We would like it to be 98 to 100, but anything 95 or higher, we will accept. 88, let me tell you something. 91 or lower, that patient's in respiratory distress. So I don't even need to tell you about 88. That's who you're going to be running to. Yes, the patient with high blood pressure who has a headache, we're going to be concerned, but it's a mild headache. We're not running to them. We're not thinking, okay, they're probably going to have a stroke. It's not like they have a severe headache. If that word said severe, we'd still go to the pulse ox patient, but we'd be running to the severe headache right away after that, right? But, hypertension with a mild headache, yeah, we'll get to them, but they're not first on the list. Patient with a UTI complaining of dysuria. Well, guess what? Dysuria, that painful urination, that's part of the disease process. That is a symptom of the disease. It doesn't mean we don't care. It doesn't mean we're not going to assess them. It just means that they're not first in line to be assessed because that is expected with the disease process, okay? We'll get to them. We'll give them an analgesic, but it's not life or death like that 88% O2 sat is. And then last, a patient who's scheduled for discharge later in the day. Guess what? If they're scheduled for discharge, and that's the only information that we have, you have to assume that they're stable enough for discharge because there's nothing in this question that tells us they're not stable. Now, the same answer that says a patient who's scheduled for discharge later in the day. If the question was, you're the nursing supervisor and who would you delegate to this patient that's getting discharged, and they would ask you, an RN, an LPN, a CNA, then that patient who's getting discharged, you would give to the RN. Why? Because any patient that's getting discharged requires a lot of teaching And it requires a lot of coordination, right? You got to make sure home health is on board, occupational therapy is on board, speech therapy is on board, physical, all that good stuff. The registered nurse. Why? Because this is complex, right? But if we're talking about priority, which patient you're going to see first, you have to think along the lines of who's more at risk to die. That's who I'm going to be concerned about. Well, I don't think I'm allowed to say the D word. I hope they don't cut me off of TikTok. You know what I mean? Who's more at risk to, okay? All right. The registered nurse is delegating tasks to a newly hired LPN. Which task is inappropriate to delegate to that LPN? Would it be administering oral antibiotics to a patient with pneumonia? Would it be inserting a Foley catheter into a patient? Would it be teaching a patient how to perform wound care at home? Or would it be collecting a urine specimen from a patient with a suspected UTI? Very good. That first word and the whole sentence made us know we're not going to give that to the LPN. We're going to give it to the RN teaching. Now, let me be clear. LPNs absolutely teach their patient, but it's not the first time the patient's hearing it. Okay. So what I mean by that, LPNs don't just give medications without, teaching the patient about the medication, but it's really more like reminders because the patient's been taught. Anything that's new, whether it's a medication, whether it's a diagnostic test, whether it's a procedure, the registered nurse does that initial teaching. Anything that is initial, anything that's first time, anything that's in depth, anything that's complex, the registered nurse does. So when that patient's admitted, it's a new admit, a registered nurse will go through all the medications and teach the patient about the medications that they're going to be taking. And once that patient is stable, they've been delegated to that licensed practical nurse or licensed vocational nurse if you're in the state of California. You think that LPN or LVN is just going to give the patient an antihypertensive agent? No, they're going to say to the patient, "Hey, I'm about to give you your antihypertensive agent. Remember, it can drop your blood pressure. So you're going to want to dangle. You're not going to want to get up immediately because you might pass out. You're going to want to press the call button if you need to get up to go to the bathroom." It's not the first time they're hearing this information. Okay. Everything else the LPN can do. Give meds. Yeah, that's skilled nursing. Inserting a Foley catheter. Yes, that's skilled nursing. Collecting urine specimen. Yes, that is skilled nursing. But teaching a patient how to perform wound care at home, that's the registered nurse. Remember how I was just telling you if a patient's getting discharged, the registered nurse has a lot of teaching to do. They're going to be teaching that patient how to care for themselves at home. How are you guys doing on the live? Is this the same for RPNs in Canada? I cannot answer that question for you. Although I have students literally all over the world. When I teach towards NCLEX in the US. I'm sure there's similarities, but I just cannot say for sure. So I'm sorry. My mouse is stuck. Mm. You receive report on 4 patients. Which patient are you going to assess first? A patient with diabetes who's sweating and confused, a patient with pneumonia who has a productive cough, a patient with end-stage renal disease who's scheduled for dialysis, or a patient with a fractured femur requesting pain medication. Who are you going to see first? Very good. That patient with diabetes who's sweating and confused. Again, whenever you get a question asking you who you're going to see first, really they want to know who's most at risk for, and that's that patient with diabetes who's sweating and confused. Now, on the live, what do you think is happening to this patient that's diabetic and they're sweating and confused? What do you think the problem is? Does anyone know? Absolutely, hypoglycemia. Let me ask you another question. What you faster? Hypoglycemia or hyperglycemia? Which one will off you faster? That's right. Hypoglycemia, blood sugar is 70 to 110. If you are confronted with these two and you have to choose a patient to see first, hypo or hypo every single day of the week. And the reason for that, if a patient is hyperglycemic, there are so many different ways that the body will try to compensate and just buy you time, right? You're hyperglycemic, you have dysuria, you have polyuria, you have polyphagia, you have polydipsia, right? These abnormalities buying you time. But if you're hypoglycemic, boom, you are on the ground, right? Hypoglycemia will you much faster than hyperglycemia. Now, the patient with pneumonia who has a productive cough, yes, they're going to need to be assessed, but there's nothing here that's telling us the patient's at risk for because having a productive cough, that's part of the disease process. Patient with end-stage renal disease who's scheduled for dialysis. If you're at end-stage renal disease, we expect you to get dialysis because the kidneys are not working. A patient with a fractured femur requesting pain medication, yes, we need to get to them, but they're not prioritized because their life is not at risk. Okay? Which of the following tasks can the registered nurse delegate to an experienced CNA? That's a certified nursing assistant, also known as a UAP. Assessing the patient's pain level after surgery, assisting the patient with ambulation after surgery, changing the dressing on a patient's central line, or administering scheduled medications to a patient. Very good. Assisting the patient with ambulation after surgery. This is something the CNA or the UAP can do. And when you guys are taking these exams, when you're testing and you're trying to decide what you can give to the UAP, I want you to ask yourself, does this require critical thinking? If it's an action that requires critical thinking, you cannot delegate it to the CNA or the UAP. Am I saying that UAPs and CNAs can't think critically? Absolutely not. I'm just telling you that's what I want you to ask yourself so you can get the answer correct. So please don't come for me in the comments. Don't email me any hate mail. I'm just trying to get you guys to pass your exams, okay? So, what can CNAs or UAPs do? They can ambulate, they can feed patients, they can bathe patients, they can take urine into output, they can do intake and output, they can take vital signs, right? Because what does that require? Recording and reporting. There is no critical thinking involved. That's why the UAPs, they can do blood pressure, they can do respirations, they can do pulse, but can they listen to lung sounds? No. Why? Because lung sounds require critical thinking. You got to know if you are listening to something that's clear versus crackles versus wheezing versus bronchi. Do you see the difference? So I'm not putting anyone down here. I just want you to pass your test. So that's how you have to think. Just say to yourself, does this require critical thinking? Now, let's look at the same answer assisting the patient with ambulation after surgery. What if you had a question that said your patient just had hip surgery or they just had a stroke and this is the first time that they're ambulating after surgery of the hip or the leg or they had stroke? Would you still be able to give this to a UAP? That's right. No. What's changed? A deficit. A deficit. This patient has a possible deficit, and so that patient has to be assessed, right? If they just had a stroke, let's say they had a stroke on the right side of the brain, they may have weakness on the left side of their body. If they had a stroke on the left side of the brain, they may have weakness on the right side of the body. The first time that they ambulate, the registered nurse has to ambulate that patient. Why? You need to be looking at that patient. Are they leaning on you or the wall for support? Are they dragging their leg? Because guess what? The registered nurse, and only the registered nurse can do this, the registered nurse would have to call the healthcare provider and say, hey, can I get a physical therapy evaluation? Maybe the patient needs a walker. Maybe the patient needs a wheelchair, right? After a stroke, the first time the patient's being fed, even though under normal circumstances, we're going to delegate feeding a patient to the UAP. Nothing wrong with that. But because there's been a change, there's been a deficit, the registered nurse has to feed the patient after a stroke. Why? Because you're watching that patient. Are you choking? Are you gagging? Are you pocketing food? Because only the registered nurse can pick up the phone to call the healthcare provider and ask for what? A speech therapy evaluation. Do we really care about the patient's speech? No. We just know that the swallow study, which is what you really want, the swallow study is done during the speech therapy evaluation. Okay. Anyway, I digress. Let's look at the other options. Assessing the patient's pain level after surgery, important but not life threatening. Changing the and by the way, the CNA wouldn't do that assessing. That's RN. Changing the dressing on the patient's central line. Changing the dressing. If we just said changing the dressing, you could have said, oh, we can give that to an RN or even an LPN, because both RN and LPNs, they can do sterile dressing changes. But look at the rest of the sentence. Changing the dressing on what? A central line. PNs and VNs cannot do central lines. Only the RN can do central lines. And then last, administering scheduled medications to a patient, RN or PN. But because they're asking us about the CNA, the only thing here that the CNA can do is the ambulation. I'm so happy most of you guys got it right. John, thank you for the roses. I see you. Thank you. Next question. You're caring for 4 patients. Which one should you assess first? A patient with chest pain radiating to the left arm, a patient with a temperature of 100.4, a patient with a leg wound and purulent drainage, or a patient who's requesting assistance to the bathroom. Thank you, Scorpio. I see the roses. Thank you. Very good. The patient with chest pain radiating to the left arm. Can you guys tell me what you think is happening to this patient that has chest pain radiating to the left arm? What do you suspect? MI. Very good. Which patient should you assess first in the emergency room? A patient with a suspected fractured wrist, a patient with a history of asthma who's wheezing, a patient with a migraine requesting pain medication, or a patient with abdominal pain rating of 5 out of 10. Who are you going to see first? Very good. The patient with a history of asthma who's wheezing. You want to know what that wheezing sound tells you? The wheezing sound tells you that there is obstruction happening. Air is trying to push through an obstructed airway. 4 of you guys chose the fractured wrist. Fractured wrist does need to be addressed, but it's not life threatening. Wheezing, obstructed airway, that absolutely is life threatening. And I couldn't believe this. 8 of you guys chose the abdominal pain, 5 out of 10. If I've said it once, I've said it a million times. There are 5 conditions that pain is considered a priority. You're going to see this patient first. And abdominal pain is not one of them. Can you guys on the live tell me what those 5 conditions are that pain is a priority? What are they? Sickle cell, very good. MI, very good. Burns, 2 more. Chest pain, well, chest pain, that's the MI, so we're still at 3. 2 more. Cancer and stones, perfect. Outside of that, it's very unlikely that you're going to be seeing that patient first that's in pain. I'm so proud of you guys. The charge nurse is assigning patients to the healthcare team. Which one is appropriate to assign to the LPN/LVN? A patient 4 hours post-op from a hip replacement with unstable vital signs, a patient with a new diagnosis of diabetes mellitus who needs insulin teaching, a patient with pneumonia who needs nebulizer treatment and vital sign monitoring, or a patient admitted with chest pain and a history of MI. Who are you going to delegate to the LPN? Very good. Whenever you get a question asking you who you're going to delegate to the LPN, let me tell you what you're looking for. You're looking for the most stable patient. You're looking for the most stable patient. You're looking for the patient that has the chronic condition. You're looking for a patient that has meds that they've been on for a while. Nothing new is going on with them. The patient with pneumonia who needs a nebulizer treatment. Look at everybody else. A patient 4 hours post-op. Again, any patient who just had surgery, we're concerned about hemorrhage. We're concerned about DVT. We're concerned about pulmonary embolism. We're concerned about infection. This is a complex patient, okay? The RN's going to have that type of patient. So that's your first red flag. And then on top of that, it says that the vital signs are what? Unstable. We're not going to give that to an LPN. Next, a patient with a what? New diagnosis. Anything that's new, a diagnosis, a medication, a procedure, a diagnostic test, it goes to the registered nurse. Why? Because it's complex. Last, a patient admitted with chest pain, first red flag, right? Because yeah, chest pain, it might just be gas. Maybe a patient has GERD, but it also might be a myocardial infarction. Can you live without a heart? Absolutely not. So they're going to need to be assessed to make sure and rule out an MI. So that's your first red flag. And then they tell you that patient has a history of MI. So even if your brain did not go to MI when you saw chest pain, you had a second reminder, a red flag that this patient's already had a heart attack before. The RN's going to see that patient. You're caring for 4 patients on the medical surgical unit. Which one should be seen first? Is it a post-op appendectomy with a heart rate of 120 beats per minute? Is it going to be a patient with a new diagnosis of diabetes asking about their diet? Is it going to be a patient with chronic back pain requesting pain medication? Or is it going to be a patient who received blood transfusion 4 hours ago and they're sleeping? Who are you going to see first? Very good. The first red flag was a patient just came from surgery. For the 1,000,010th time, any patient that comes from surgery, we're concerned about hemorrhage, we're concerned about DVT, we're concerned about pulmonary embolism, we're concerned about infection. That was our first red flag. And then they go on to tell us that that patient's heart rate is what? 120 beats per minute. What's your regular heart rate supposed to be? 60 to 100. Why is the heart rate so high? Most likely they got internal bleeding. That patient's hemorrhaging out. You look at the labs, you see the heart rate up. You see the blood pressure down. You see the RBC down. You see the H&H down. You see the respirations up, and you see urine output down. What's that sign and symptom of? Hemorrhage, internal bleeding. Let me tell you something, not for nothing, but, and I'm completely getting off topic, but I'm telling you this, whenever you see increased heart rate and increased respirations together, you don't know what's wrong with the patient, but you know that that's your priority patient. Something is severely wrong with the patient. Whenever you see the lung and the heart compensate together, both are going up, that's the patient that needs to be assessed. Something severely wrong. Don't say I didn't warn you. How are you guys doing on the live? Okay, Channy says a patient that came post-op, a patient that came 24 hours post-op will be question mark. Okay. So if it's been 24 hours, we're still going to be concerned about them bleeding out. We're still going to be concerned about them developing a DVT or pulmonary embolism and infection. And to be honest, the first 12 hours after a patient's had surgery, it's more likely the first 3. It's more likely a DVT, pulmonary embolism, or hemorrhage. Why? It takes time for you to develop infection. If the patient just had surgery and pathogens have just been introduced into that patient's body, it takes time for them to build up an immune response. It takes time for us to see the temperature go up, for us to see, ESR go up, for us to see CRP go up, for us to see WBCs go up, right? It doesn't happen right away like the first three can happen. After the first 12 hours, that is when it's more likely for us to see infection. Did I answer your question? Okay, good. Brandy Wine says, I was taught less than 12 hours, they're considered unstable, but more than 12 hours, they're considered stable. Brandy, no disrespect to your instructor or your school. However, I'm telling you right now, for testing purposes, your patient is not deemed stable until the registered nurse has assessed that patient, deemed them stable. And even then, things can change. So within that first 12 hours, we're going to be assessing them very closely to see if things develop like what I mentioned, but that patient's not deemed stable until they've been assessed. So that means as soon as that patient comes to your floor from the OR, automatically they're considered unstable until the registered nurse has assessed them. Okay? Then if everything is within normal parameters and there's nothing new going on with that patient at that point, the RN can delegate to the LPN if that happens to be the most stable patient, if that makes sense. Exactly. Perfect. That's exactly what I meant. Depends on the progress of the patient. Absolutely. Don't go by time frame, guys, because NCLEX does not like the students who try to like be a robot and put everything in the box. No, they want you to think critically. Okay? All right. Which task is appropriate for the registered nurse to delegate to the licensed practical nurse? Would it be teaching a newly diagnosed diabetic patient how to administer insulin, administering an IV push medication to a patient with sepsis, assessing a patient who's complaining of chest pain, or administering sub-Q heparin to a patient with DVT? And I'm sorry, guys, I'm spending a lot more time on this Kahoot than I normally do, but I'm very passionate about priority and delegation because they kill you with priority and delegation on NCLEX. I kid you not. And if you guys can understand priority and delegation, there's so many questions that you may not understand the medication, you may not understand the disease process, but if you understand priority and delegation, you'll still get the answer right. Okay, so I'm sorry, I'm spending a lot more time on this. Anyway, which one will we delegate to the LPN? I'm happy most of you guys got it correct. Giving sub-Q heparin to the patient with DVT. Teaching RN. IV push. Let me tell you something. IV push, RN. Central line, RN. Piggyback, RN. Blood, RN. Care plan, RN. New medication, new admission, new diagnostic test, RN. Discharge, RN. Okay. And last, assessing, of course, RN. Imani, that's not true. That absolutely is not true. Imani said LPNs do not give IVs. They absolutely do give IVs. There are only a few states that LPNs don't give IVs. They can give IVs. They just have to have like, extra training or certification. But for most states in the USA, they absolutely can give IVs. They can't do IV pushes. They can't do piggybacks. They can't do central lines. They can't do blood, but they can do IVs. Who told you that? What state are you in? Okay, one more. All right, last one. Which task should the registered nurse delegate to a certified nursing assistant or UAP? Monitoring the patient's INO for 8 hours, performing sterile dressing change on a surgical wound, developing a care plan for a patient with chronic heart failure, or administering oral medications to a stable client. Oh, guys, the TV in my office has been fixed, so this is the last Kahoot I'll be doing in my room for a while. I'm happy about that. Okay, monitoring INOs, because when you're thinking about the UAP or the CNA, just think about record and report. They can record and report, INO. Vital signs, right? Flow sheets. Sterile dressing change, that would be RN or PN, because PNs can do sterile dressing changes too. Now, if it's on a central line, only the RN. So depends on the location. Developing a care plan, only the RN. And administering oral medications, that would be the RN or the LPN. And guys, that is it for this Kahoot. Let me know in the comment section what you thought about this Kahoot. If you'd like to see more Kahoots, or maybe you want me to teach a lecture, Q&A, whatever. Let me know in the comment section what you'd like to see me cover next. Let's see how you guys did.